Good morning. Today I'll be talking about medial collateral ligament of the knee, or MCL. The main function of MCL is to resist valgus angulation, and also it works together with ACL to provide restraint against axial rotation. The anatomy of MCL, it originates from medial femoral condyle, and it inserted into medial tibial condyle. It has deep and superficial portion. The superficial portion, also known as tibial collateral ligament, it originates from medial femoral condyle. It's about 1 centimeter anterior and distal to adductor tubercle, and it inserted into periosteum of proximal tibia, deep and posterior to the pes anserinus. It is the primary stabilizers to the knee for against valgus stress at all angles. The deep portion is also known as medial capsular ligament. It is within the knee joint capsule. It attached to the medial meniscus and divided into meniscofemoral and meniscotibial ligament. The posterior fibers of the deep MCL blend together with posterior medial corner, and they both act as a secondary restraint to valgus stress at knee in full extension. The blood supply for MCL is from superior medial and inferior medial geniculate arteries. MCL has strength of 4,000 Newton against valgus stress. The MCL injury is most common ligamentous injury in the knee. It accounts for about 40% of the knee ligament injury. It is more common in males compared to females. The most common mechanism for MCL injury is sudden valgus force to the lateral aspect of the knee, with knee slightly flexed and externally rotated. The MCL injury can be contact and non-contact. The contact MCL injury is more common than non-contact. It usually involves direct blow to the lateral aspect of the knee, and commonly resulting in high-grade or complete tear of the MCL. Non-contact MCL injury, less common, commonly occur in skiing. It involves pivoting and cutting activities with valgus and external rotation forces. It usually resulting in low-grade or partial MCL tear. There are other associated injuries with MCL injuries. The most common one is ACL injury. About 95% of ACL injury associated with non-isolated MCL injury. Other associated injuries is meniscus tear. Medial meniscus more commonly tear compared to lateral because its attachment to the MCL. Other associated injuries is Pellegrini-Stridor syndrome, which is classification at medial femoral insertion sites. Usually results from chronic MCL deficiency. The presentation of MCL injury, usually patient presented with medial joint line pain, and they had a pop sound during the injury. Patient also had difficulty ambulating due to pain or instability after the injury. For physical examination, from inspection we can appreciate swelling and ecchymosis. Patient will present with anti-jig gait. On palpation, there will be effusions, tenderness of MCL or medial joint line. ROM might be limited due to pain, and the special test for MCL is valgus stress test. If valgus stress test positive at 30-degree flexion, it indicates isolated superficial MCL injury. If valgus stress test positive at 0-degree flexion, it usually associated with other ligament injury such as posterior medial corner and ACL injury. But full knee examination should be done if you suspect MCL injury to look for any other associated injuries. The two classifications for MCL injury. The first one is AMA, or American Medical Association classification. It is based on joint laxity alone when performing valgus stress test at 30-degree flexion. If grade 1, there's a 3 to 5 millimeter opening. Grade 2, 6 to 10 millimeter opening, and grade 3, more than 10 millimeter opening. For other classification is Houston modification of AMA classification. It is based on joint laxity and severity of the injury. Grade 1, it is a mild injury with a firm endpoint and no joint laxity. There's a stretch injury of your MCL fibers torn. Grade 2, it is moderate injury with partial or incomplete MCL tear with firm endpoint plus minus mild increase in joint laxity. Some MCL fibers still remain intact. Grade 3 is a severe injury with complete MCL tear and no endpoint with valgus stress. The investigation for MCL injury, we can do an X-ray of the knee, AP and lateral, to look for sequence fracture for associated ACL injury, and also to look for pellegrini-stridal lesion which indicates old MCL injury. Ultrasound also can be done to look for MCL tear, but MRI is the best choice to look for MCL tear and other associated injuries. The management for MCL injury can be divided into acute and chronic management, operative and non-operative management. For acute management, we can use Price principle. We can protect the knee with a hinged knee brace. We can put rest and ice compression, and also elevate the limb. NSAIDs also can be used concurrently to reduce the pain. Patient should also be prescribed with home-based exercise to strengthen the quadricep, such as isometric quadricep contraction and SLR. For chronic management, it can be either conservative with the brace or operative. Usually grade 1 and grade 2 injury respond well to the conservative management. For operative management, it can be either ligament repair or reconstruction, usually done for grade 3 injury. For ligament repair is the best option for acute and subacute injury. In acute repair, the indication is for multiligamentous injury, and there's an entrapment of the torn end of the MCL in the medial compartment. For subacute repair indication, it is indicated when there's a continuous instability despite conservative management with 10 mm opening at the medial side in full extension. For chronic injury, reconstruction is the best option due to loss of adequate tissue for repair. Thank you.